can start.
Okay. Good morning all and welcome to another SADA webinar aimed at educating members of the public and empowering you with knowledge. As you may be aware, September is National Oral Health Month in South Africa, and for this reason, today we will be discussing the role of the periodontist in a healthy mouth. Our esteemed speaker for this morning is Dr. Suzette Stander, a dental specialist in periodontics, implantology, and oral medicine. She is currently in private practice in George and also serves as the president of the South African Society of Periodontics, Implantology, and Oral Medicine, or SASPIO, for the 2023 to 2024 term. Welcome, Dr. Stander, and thank you so much for joining us today. Over to you.
Thank you so much. So first of all, I would just like to give a little bit of background. What is a periodontist? A periodontist is a dentist who specialized and trained an additional 4 years at the dental school in the following 3 disciplines of periodontology, implantology, and oral medicine. They specialize in the diagnosis, prevention, and treatment of periodontal disease and periodontal defects, dental implant treatment, and the management of implant diseases, as well as the diagnosis and management of oral diseases and conditions. So what's the role of the periodontist in each of these different 3 fields? We look at periodontology. A healthy periodontal tissue is the framework to a beautiful smile. So to understand periodontal disease, one needs to appreciate periodontal health. So the healthy gingiva, under healthy conditions, the gum has a pink-orange peel stippled appearance without any signs of bleeding, and the interdental papilla are the knife-shaped gingiva closing the contacts between our teeth. The gum thickness that rests on the underlying bone measures approximately 1 to 3 millimeters, and we refer to that as the healthy periodontal pocket. Genetics also determines if one is born with a thin scalloped gum or thick flat gingiva. The gingiva is less resistant against trauma if it's thin and more susceptible to recession. So periodontal disease is primarily caused by a plaque or bacteria that is referred to as the biofilm. It is a complex communities of microorganisms that interact with each other and the host, which are structured in organized polysaccharide matrices and adheres to different surfaces in the oral cavity. A dysbiotic biofilm is when there's an imbalance of good and bad oral bacteria that leads to dysbiosis and subsequent disease. By practicing good oral hygiene, the biofilm in the mouth is kept in balance. Other causes that also plays a role in the development of periodontal disease includes genetic predisposition and systemic factors such as diabetes as well as smoking. The capability of the body's immune system to fight off the bacterial infection is important, and immune system fluctuations may spark flare-ups of the disease. So periodontal disease is primarily divided into either gingivitis, which is reversible, and then periodontitis, which is an irreversible condition. If we look closer at gingivitis, it's a common and mild form of periodontal disease that causes irritation and or inflammation of the gums around your teeth. Although it is a mild condition, if not treated promptly, it can lead to a more severe case of periodontal disease or periodontitis. Gingivitis is most commonly caused by bad oral hygiene and can usually be prevented or reversed by maintaining good home oral hygiene, such as brushing twice daily and flossing daily, and keeping to regular checkup appointments with your dentist or oral hygienist. Signs of gingivitis include swollen or puffy gums, bright red or dark red gums, bleeding gums when brushing or flossing, bad breath, receding gums, or sore tender gums. And risk factors includes poor oral hygiene, smoking or chewing tobacco, older age, dry mouth, poor nutrition or diet, dental restorations that doesn't fit properly, or crooked teeth that are hard to clean, conditions that decreases the immunity, such as leukemia, HIV/AIDS, or cancer treatments, certain medications taking a large amount of different medications, hormonal changes, genetic factors, and some medical conditions such as viral and fungal infections. If you notice any signs or symptoms of gingivitis, we urge you to take it seriously and schedule an appointment with your dentist as soon as possible. The sooner you seek care, the better the chances of bringing the condition under control and preventing regression to periodontitis. So periodontitis is when gingivitis is left untreated and it can progress into periodontitis, which is induced by bacteria and is a chronic inflammatory disease which permanently destroys the supporting structures of the tooth, such as the attachment of the root to the bone and the soft tissue that supports the teeth. Periodontitis, if left untreated or already in an advanced state, can cause tooth loss. Recent research has also proven that the bacteria responsible for periodontal disease can enter the bloodstream and affect your heart, lungs, and other parts of your body, causing greater complications such as respiratory disease, diabetes, coronary artery disease, and strokes. In severe cases, periodontitis end result is tooth mobility, the gum or tissue pulling away from the teeth, and eventually tooth loss. Symptoms, sometimes periodontitis can be asymptomatic or not really painful, but when symptoms are present, they include swollen gums, discolored gums, bleeding gums when you brush or eat, or even spontaneous bleeding, a longer appearance of the teeth or receding gums, increased spacing between teeth, pus between the tooth and the gum, increased tooth mobility and spontaneous loss of teeth, bad taste in the mouth, and a bad breath or halitosis, and pain during chewing or mastication. Risk factors include gingivitis, poor oral hygiene, smoking and chewing tobacco, hormonal changes that we see during pregnancy and menopause, substance abuse, obesity, poor diet, genetics, certain medications that may lead to dry mouth, systemic diseases such as diabetes, HIV, and cancer. Then if we look at general health, in periodontitis, the bacteria on the tooth root and gum causes an immune inflammatory response, resulting in a swollen and damaged gum. With brushing and eating, the plaque enters the bloodstream and travels to distant sites throughout the body, affecting the health of the internal organs. And there's a lot of research that shows an association between periodontal disease and various systemic conditions. These include diabetes mellitus, and there's a double link, coronary heart disease, stroke, rheumatoid arthritis, certain cancers, chronic kidney disease, preterm birth babies, and respiratory disease. If we look a little bit closer at the heart, certain bacteria causing periodontitis are structurally equipped to attach and penetrate the blood vessel walls. Within the blood vessel wall, the bacteria can multiply to elicit an inflammatory immune response and causes blood vessel cell death. The result is hardening and narrowing of the blood vessel walls, called atherosclerosis. Now, atherosclerosis leads to heart attacks and strokes, and it accounts for almost 29% of deaths worldwide. If we look at diabetes mellitus, there is emerging evidence that supports an increased risk for diabetes onset in patients with severe periodontitis. And this may be due to elevated systemic inflammation of the acute phase and oxidative stress biomarkers resulting from the entry of bacterial organisms and their virulence factors into the circulation. There is a direct and dose-dependent relationship between periodontitis severity and diabetes complications. So how does your dentist or oral hygienist screen for periodontal disease? So the extent of the condition is usually established in a clinical examination or a basic periodontal examination where the soft tissue gum around the teeth is inspected and x-rays are taken to check the bone levels around the tooth. So what we use for a basic periodontal examination is, and if you look closer, a periodontal probe. It's an instrument with different markings at the tip, and this guides us to measure the distance from the gum to the bone level around the tooth. So with a basic periodontal examination, your dentist will divide the mouth into different 6 areas, and they will check the teeth in each of these 6 areas to see if there's bleeding after they run the probe with gentle pressure around the gum, if there's calculus, plaque that is hardened on the tooth surfaces or underneath the gum, if there's also measurements of 4 or 5 millimeters or deeper pockets of 6 millimeters or more. And if they see that there's measurements of 4 or 5 millimeters or more, then it is recommended that you do a comprehensive periodontal examination. And this is where the periodontist's role becomes more prominent. So periodontist will then go and do a more detailed comprehensive examination, check 6 sites around each tooth, and record this together with small x-rays of the mouth, and a diagnosis of the periodontal condition will then take place. And we make use of the new classification, the 2017 classification that was produced by the European Federation of Periodontology and the American Association of Periodontology. So I think what's important to remember that once we diagnose periodontitis, a patient always remains a periodontitis patient. So first of all, what is important with this classification, what makes it significant, is we now notice or make note of a staging and grading system. The staging system will show us, we will look closer to the worst affected clinical site. We'll take a smaller x-ray. We'll look at the bone level around that worst affected site, and it will tell us, or we will divide it into either it being a mild early form, a moderate, severe, or very severe case. We will also have in this classification a grading system where we look at the percentage radiographic bone loss, and we take the patient's age into account, and that gives us a degree of the rate of bone breakdown that we can see in the condition. But there are certain grade modifiers, such as smoking and diabetes mellitus. And with smoking, if a patient smokes more than 10 cigarettes a day, it does make the condition or the effect of the condition more severe. And the same with diabetes. If it is uncontrolled, we consider the rate of bone breakdown more severe than in a controlled diabetic patient. But let's talk more about the treatment of periodontal disease. There is currently no known cure for periodontitis. However, the condition can be brought under control and maintained with regular checkups with your periodontist. The sooner the condition is picked up, the less invasive the treatment will be. If you notice any signs or symptoms of periodontitis, we urge you to take it seriously and schedule an appointment with your periodontist as soon as possible. The sooner you seek the care, the better the chances of bringing the condition under control and preventing further complications and systemic involvement as well. Depending on the severity of the condition, periodontitis can be treated either with a non-surgical treatment therapy or a surgical deeper cleaning procedure. So if we look at the non-surgical treatment therapy, we will provide the patient with oral hygiene instructions based on their specific needs. We will motivate and coach them how to clean the mouth more effectively. We will identify risk factors and also advise on how we can control those risk factors. We will clean or debride all the plaque or calculus supragingivally as well as subgingivally, and we will use subgingival instrumentation for that. And it can be also with or without adjunctive therapies. But when we move to surgical therapies, usually this is when the non-surgical therapy is less productive. Surgical therapies includes access therapy, surgery or access flap procedures, resective procedures where we take a little bit of excess gum away so that the patient can clean more effectively, or regenerative procedures where we want to stimulate bone growth or modify the defects that's created. But very importantly, and not taken out of consideration, is supportive periodontal care program that the patient needs to be placed on afterwards. So although it's of the utmost important that the periodontist perform the necessary periodontal treatment and supportive periodontal care, it's just as imperative that the patient also adheres to good oral hygiene for long-term success of treatment. For a healthy mouth and long-term stability of their periodontal disease, our patients should brush and floss twice a day, adhere to regular periodontal maintenance appointments, such as the supportive periodontal care, to mechanically reduce the plaque levels in the oral cavity, and to check for periodontal flare-ups, or to prevent further breakdown of the supporting periodontal tissues, the bone and the soft tissues. Thus, there is a joint and synergistic responsibility between the periodontist and the patient in maintaining a healthy mouth. The success of periodontal therapy is based on the patient's ability to maintain optimum oral hygiene at home. And if we look at how can the patient maintain good hygiene at home, if we take into account the European Federations of Periodontology's workshop guidelines, regards to toothbrushes, our toothbrushes showed a statistically significant additional reduction in inflammation and of plaque levels compared to your manual toothbrushes. And with regards to oscillating versus high-frequency sonic brushes, there is moderate evidence for a very small benefit of oscillating rotating mode brushes. Then if we look also at interdental brushes, so interdental brushes is the device of choice for interdental plaque control, and the rubber interdental brushes showed weak to very weak evidence for plaque reduction in patients with gingivitis. But for our periodontitis patients, where there's bigger gaps forming in between the teeth, the rubber interdental brushes or picks are much more efficient than toothbrushing alone to reduce plaque and gingival inflammation. Then if we look at flossing, flossing is not really recommended except for healthy sites where interdental brushes cannot pass without trauma. But where there's bigger spaces forming between the teeth, it's recommended to rather stick to your interdental brushes. Toothpaste. So there's the most important thing, toothpaste alone won't control the plaque levels. Does play a role, but the main factor for plaque removal is the mechanical action of a toothbrush. However, there's moderate good evidence that using active ingredients in toothpastes, such as triclosan copolymer and stannous fluoride, can significantly improve the clinical ability to inhibit plaque compared to using regular sodium fluoride toothpaste. And these toothpastes can provide added plaque inhibition benefits for a patient. Then if we look at chemical biofilm control in periodontitis patients, so it's a very important aspect of periodontal therapy, especially for patients who are unable to sufficiently remove the supragingival plaque through mechanical methods alone. And there you can look at antiseptics in certain toothpastes. And these antiseptics, most importantly, is chlorhexidine. It's a well-established antiseptic with proven efficacy in reducing plaque and gingivitis. Triclosan copolymer, which is a broad-spectrum antimicrobial agent that effectively inhibits bacterial growth, and stannous fluoride sodium hexametaphosphate. It's a combination of fluoride and phosphate compound that provides antimicrobial and anti-calculus or hard plaque benefits. Then if we look also at antiseptics and mouth rinses, again, chlorhexidine, it's a well-established antiseptic with a long history of use in oral health care, and there the concentration of 0.1% or more becomes important for our periodontitis patients. Essential oils in mouth rinses is also very good to use. It's a natural alternative with antimicrobial properties, often used in combination with other agents. And then the cetyl pyridium chloride, or CPC, which is a broad spectrum antimicrobial agents that effectively also reduces plaque and gingivitis, is good to use. Then if we also look at certain mucogingival procedures where periodontists can play an important role, we also perform gum grafting procedures. So a soft tissue graft is usually done when a patient presents with bone and soft tissue loss or recession, which makes the teeth look longer and is generally not aesthetically pleasing to look at. This can affect one or more teeth. And there are many factors which can cause gum recession, such as trauma, previous orthodontic treatment, but periodontal disease still remains the most common factor. And by performing soft tissue graft on recessed teeth, we can restore lost bone and gum in an area for a patient. We usually harvest soft tissue from the palate, and the grafted or transplanted tissue is then seated in the defect site. And bone regeneration can also be done to regenerate new bone growth in the site for better long-term prognosis. We also do crown lengthening procedures. Certain requirements or reasons can be when a crown is broken off and does not allow enough tooth structure above the gum for a prosthetic crown to be placed, or where there's a cavity below the gum line which needs to be restored by the dentist. When patients grind their teeth, the crowns become shorter and shorter to a point where there's not enough tooth structure left for restoration, and the crown needs to be lengthened for prosthetic crown to be placed. And with a crown lengthening procedure, part of the gum is gently lifted away from the defect site to gain access to the bone structure surrounding the tooth, and some of the bone is removed around the neck of the tooth to enlarge the exposed area of the tooth, and the excess gum is also trimmed away around the remaining gum. It's then resecured to allow for the restoration to be placed. Gingivectomy procedures is also a partial removal of the gum around the tooth to treat the gum disease, or also to increase the height or width of teeth. And some patients are born with excess gum or a gummy smile, or present with excess gum due to trauma, hormonal changes, medications, orthodontic work, or other factors. And then there's also gingivoplasty procedures, where a specific area of the gum that can present with an uneven gum line, we can make the gum appear more natural by altering some areas of the gum through gingivoplasty. And if we look at implantology and what an implant is, a dental implant is a screw-like surgical component that interfaces with the bone of the jaw to support a dental prosthesis, such as a crown or a bridge or a removable denture. And after an implant is placed, there's usually a variable amount of healing time that is required for the bone to grow on the implant surface. An implant also consists out of 3 components. First component is this little screw-like structure, and the surface of the implant is also turned, and this is placed within the bone and integrates with the bony structure. The third or second component is a little abutment that fits onto the implant screw, and this usually penetrates above the gum. It stretches the gum and it prepares the gum for the crown to be seated. And then the crown, which is the tooth that we see on the in the mouth, this is usually placed then by your dentist or prosthodontist. But that's the 3 components an implant consists out of. And your periodontist and dentist will also evaluate the site and determine, if there's enough bone, if there's enough soft tissue, and there's various ways that they can go about this. Most importantly, they will take a more specialized radiograph or a cone beam computer tomography or CBCT scan to evaluate the thickness of the bone, the width of the bone, and the distance from important structures, as well as clinical examination to determine if there's enough soft tissue. But most importantly, the correct 3D positioning of the implant is important so that the crown can be seated in the right position. But implants isn't always the answer to everything. Just as a tooth, an implant can also get infected. So it's important to know that maintenance around an implant after an implant has been seated is very important. And if we look at peri-implant diseases, there's two main types of peri-implant diseases that we can find. Peri-implant mucositis is when only the gum is infected and inflamed. This can usually be treated and the condition reversed if it is caught very early. But periimplantitis is when the infection has regressed to such an extent that the soft tissue and the underlying bone is affected. And it is noted by blood or pus draining from the gum around the implant, and the gum around the implant can also become swollen and even recede to expose the underlying implant body. And on a radiograph, bonus around the implant will be seen. And this condition usually requires surgical treatment, but the sooner we pick up peri-implant disease, the better. And that's why our subsequent appointments with your dentist or periodontist is so important, so that we can identify risk factors which can lead to peri-implant disease. And these includes the history of periodontal disease, if there's poor oral hygiene, and other systemic conditions which may lead to infection. So the goal of supportive periodontal care or these maintenance support appointments is to detect if there's implant complications, to re-establish periodontal health, but primarily to reduce the amount of plaque and therefore reduce further disease progression around an implant. Then the last leg of what the role of the periodontist does is oral medicine. So oral medicine is a specialty of dentistry related to the medicine of soft tissue diseases of the mouth. It involves the diagnosis and non-surgical management of medical conditions in the mouth and nearby structures. And there's many systemic diseases that have signs and symptoms that can manifest in the orofacial area. So an oral cancer screening just may save also a patient's life. So cancer is a disease that occurs when uncontrolled division of abnormal cells in the body occurs, and these cells are referred to as malignant and cancerous. Oral cancer occurs in the lips, usually in the lower lip, inside the mouth, salivary glands, tonsils, on the back of the throat, the esophagus, and most likely also on the tongue and soft tissue in the mouth. So signs and symptoms of oral cancer includes mouth sores that doesn't heal, mouth sores that bleed spontaneously, velvety white, red or speckled, meaning red and white patches in the mouth that is persistent and doesn't go away, hard raised lesions or bumps, crusts, eroded areas on the lips, gums, or other areas inside the mouth, persistent pain in the mouth, difficulty with chewing, swallowing, speaking, or movement of the tongue, or other oral autoimmune conditions such as lichen planus, which is considered a premalignant lesion. So a cancer screening is a precautionary measure and not a diagnostic measure. It is found that there is nothing to worry about. The patient may be requested to return for follow-up appointments to monitor the area or areas for any changes that may take place over time. And an oral cancer screening is both a visual and a physical evaluation of the oral cavity and the surrounding areas of the face and neck. A screening may be done on a patient's request to set their mind at ease or as a result of a referral from another physician who may be concerned about the patient's health. So there are different tools that we can use, less invasive tools to help us with the diagnostic process. We can use certain staining to highlight areas on a suspicious lesion, which may require more specialized investigation. These can include methylene toluidine blue staining or tissue reflective techniques such as the microlux or Visilux or autofluorescent techniques. But I think a very simple tool to use, and this even dentists can use in their practice, is a little tiny brush like this, or transepithelial cytology. This is the oral CDX brush. So what we do is, in a suspicious lesion, we would run this brush on the surface of the tissue so that it penetrates the epithelial layer. And these little bristles collects the top layer of the cells. We put it in a solution and it gets sent to a pathologist where they evaluate the different cells if there's any abnormal cells. And if the results comes back that there is the presence of abnormal cells, this may guide us that more specialized investigative techniques needs to be required, which can include usually a scalpel tissue biopsy, either incisional or excisional. Now, biopsy, it's a simple procedure that's done in the dental chair. Usually the area of concern is anesthetized and a small piece of the tissue is excised, sent to the laboratory. And this allows us to look under a microscope at the various layers of the cells. And we can see how deep the lesion is penetrating into the tissue and what cells exactly is happening. And we can make a more definitive diagnosis to allow for better treatment. Okay, so if you present with a suspicious lesion, I think the most important part is if it doesn't go away, if there's pain and you're concerned, seek the assistance of a healthcare professional. There are periodontists and oral medicine specialists out there that specializes in these techniques. Less invasive techniques can be used to put your mind at ease if it's really necessary to be concerned before more specialized investigative techniques or invasive techniques are used. But don't wait. There we go.
Thank you so much, Dr. Stander. That was very detailed and informative, and I'm sure the members of the public will will learn a lot from that webinar, and they'll be able to be much more informed now when visiting the dentist or the periodontist. So thank you so much for your time. I see we don't have any questions this morning, so I'm going to close off the session. Have a great day further.
Thank you. It was my pleasure. Have a lovely day.
Thank you.
Bye.